Good afternoon, everyone. Welcome to our monthly edition of Health Tech Talks with PCQuest. So we started this initiative some time back, and we do it regularly. And every time we pick up one, crucial and key aspect in the health tech scene. So this time we are going to be discussing the all important issue of EHR EMR, that is the electronic health records and the electronic medical records. So basically that's now, if we truly have to go to the next stage, then we have to go in for a proper EHR and EMR system. So basically that is the topic of the panel discussion today, that India needs a robust EHR and EMR ecosystem. And for this, as usual, we'll be bringing in the experts and they'll be telling you what it's all about. So our first expert is Angshuman Sarkar, Principal Consultant at Thoughtworks. Welcome, Angshuman.
Thank you. Thanks for having me here.
Yeah. And our second expert is Rupa Rao, co-founder EHR.Network. Welcome, Rupa.
Hi, happy to be here. Looking forward to the discussion.
Yeah. So actually, what we do is whenever we take an important topic, before we go forward, we look at a little, back. What has been the history of this thing? So, I mean, when you look at EMR and EHR, probably it would be good to discuss that what was the scene pre-COVID, and what was the status of these records till 2019. And as you know, in the last 2 years, the pandemic has changed every industry. There has been technological acceleration while it hit other industries. So maybe you can tell us what the last 2 years of the pandemic did it to make it better or worse. So I think anyone can go first. I mean, I want to keep this as informal as possible.
Sure.
Yeah.
So
shall
Madam,
I?
you want to go first? Yeah, please.
Yeah.
okay, Rupa, then you can go first. Yeah.
Yeah.
Thank you.
So pre-COVID, for most of us, and I see, I'm just going to take the aspect of outpatient, our consultation with the doctor. So typically, what was there pre-COVID was that there were paper records wherever you went, and then the patient always had a copy of the record. And whenever you met a practitioner, there was a clear expectation that you actually were responsible for managing your records, that you had the master record. Some of the practitioners and service providers were maintaining it electronically, but the master, where all the diagnostic reports, all the there, were with the patient. Now, now what we see is everybody has started maintaining the data electronically. So what that electronically means itself, there's a broad spectrum, and maybe we will get into the details later. And what I feel is this drive that they want to start maintaining it electronically, I see a few clear reasons for that to happen. One is, earlier the patient would actually carry the records. Now the doctors do not want to be handling those records, so they do not entertain your records. So they've started maintaining records themselves, and if they had your records earlier, many of them have ensured that all of it is updated and is available. So that is one clear change that I see. Now the second thing is, like, why they've done this, I feel, is because everybody has to get ready for teleconsult, and that data, that context is required. So they're doing that. Third one is, whenever you go now for a consult and the data is getting created, nothing is written on paper and given to the patient. And if you want something for your records, you have to explicitly ask, and for a copy, and they probably give you an encounter summary. So this is probably a stickiness, a way of stickiness that they're seeing. Then many providers now are providing a mobile app where you can go and see the data that they have generated for you during your encounter. So that is also happening. So these are all post-COVID changes that are very, very there. But in all of this, even today, it's a silo approach. Every provider is creating it electronically, but it's for them. It's for your interaction with them. And then another key difference that I'm seeing is, earlier, whenever applications or solutions were provided, the practitioners were always, there was a resistance to kind of enter data. Now, when you see, they have figured out how to do that and ensure that the interaction, patient practitioner interaction stays good. So there's somebody else who's entering data, that the doctor is talking and data is getting entered and it's all getting captured. So all these big changes have happened. Acceptance that electronically data has to be maintained by the service provider. I'm seeing it very clearly in all my interactions.
So that's good to hear that acceptance is happening. So maybe I guess Angshuman can get.
Yeah. So, I mean, I'll probably come from a different perspective, right? Like,
Yeah,
if you
that
look
would
into,
be good. We'd have two different perspectives. So that's
yeah.
good for our discussion.
So 2019, think about it, like, and the, like, Indian market, for example, EMR, EHR market was something like, say, 200 million USD, all right? Like, which you can think about, compare it with, like, say, any other developed countries or developing countries, nothing, right? We were supposed to grow CGPR rate of about 6%, very optimistic again, right, that point of time. And to talk about some empirical data, think about National Cancer Grid of India, where probably electronic medical record is the most valuable, right? Because for continuum of care, for quality of care, for chronic diseases, and I can tell you from experience that probably, like, even 25% of the hospitals in the grid didn't have a EMR at all. I mean, they did have a patient management system and a billing systems, many of them, but none, right? Like, so, I mean, I would say even today, organizations who value, for example, quality aspect, research aspects, you'll see them, like, uptake of EMR as such institutions being much more. Now, obviously, COVID has shifted mindset. One big mindset of people was, is it going to, am I going to lose the human connect, right? Which ma'am also mentioned, is like, doctor saying, like, will my focus be on the, like, entering the data, looking at the screens? Am I losing that human connect with the patient? I think that apprehension has gone a lot. But at the same time, I would like to say that that behavior change is probably, and whatever the advantages that we are seeing are probably more for, like, people in the metros, right? Like, leveraging teleconsultation. And in teleconsultation, you have to generate, like, at least an electronic document, because without which the subsequent, like, say, processes, fulfillments for medications, or even otherwise, like, say, get some investigations done is not possible. But how is it different from a handwritten note? Somebody takes a picture and uploads it. So I still do not think that people are using structured medical records for quality of care. I mean, I can tell you, and there's that none of the government, like, facilities, for example, are generating that, right, which much of our population depends on. So I would say it is sparse. Obviously, people have started using, like, digital interventions more, but is it really a electronic medical record? I doubt very much about it.
So that's quite interesting. I think we'll take up some of these issues later. But before I go forward, I'd be interested in, like, both. Thank you for both of you have given an overview from your respective things. But I'd be more interested in knowing what your companies have done in specifically for this. So, like, both from your EHR network and Thoughtworks point of view, what specifically have you done in this domain? If you could tell.
So a few things, right? Like, obviously for COVID response, like, we have carted out, like, as part. So Thoughtworks, before I say that, Thoughtworks actually uh, built an open source health information system. We just don't call it an EMR because it functions, does other functions of a hospital as well. And one of the pressing need was, like, teleconsultation. All right. Again, we provided that, again, entire, like, an open source stack. that was highly appreciated. COVID sort of a follow-up monitoring. This was another aspect that we introduced, which was not there, right? Interfacing with like the ecosystem, for example, is another thing that we have done. That is on the EHR side, but Thoughtworks specifically has actually also worked with National Cancer Grid of India to implement the national health stack, which was like, Niti Aayog came out in 2018, and we have been involved in various capacity. And I'm glad to say that today what you hear about, say, ABDM, right, the first version of the Federated Health Records, which forms the India's Health Information Exchange, actually came out from the work that Thoughtworks did with National Cancer Grid of India. So that is probably the most significant work that we have done. At least the first version, the specification came from there.
So shall I? Okay. So for EHR.Network, we are like 6 years old, and what our focus has been in the last 6 years is EHR.Network is a data first platform for healthcare, and it has a set of services, including a EHR service that's based on the open EHR model, demographics, and several other services that we can talk about. And all of these services are exposing REST APIs. And our model is this enables health tech applications to be built, where what we're actually discussing today in the context of EHR and EMR is the health data being managed in a structured manner? Is it being managed in a manner that it is interoperable, semantically interpreted? So that has been our focus, that building this, providing this infrastructure as a cloud service will enable the ecosystem to come out with several solutions, including EMRs, which can be deployed and which will start managing data in a very structured manner. So that has been our focus in the last 6 years. And in the context of what we've done in the last 6 years, EHR.Network is the platform on which the government of Karnataka's mental health management system is based, where all mental health information. So this system was rolled out in Karnataka, and NIMHANS was the domain expertise, and IIITB was handled the technical aspects of it. We got an opportunity through IIITB, and the EHR.Network is the platform on which the entire data for clinical data, demographic data, the registries are all being managed by EHR.Network. And this is deployed now in the state's data center, and deployed for a huge dimension of like 1 million patients for in the public health mental management. So that has been. And in COVID, we also have a service for decision support. So we had a CDSS which enabled assessment, COVID assessment. And this was used a lot in the second wave, and Jharkhand was one of the states where it was used. So the last reports that we got was there were around 4 to 5 lakh hits, and what this enabled was the mobile application that was using this service was being used by non-medical professionals in the rural areas to actually do an assessment and to determine what the next steps could be. So that is something that we've done. The third thing that we've actually done that EHR.Network is used for is there's a solution called Ayush EHR, which is focused on Ayurveda and yoga. So again, the platform that is supporting the solution is EHR.Network. So Ayurveda clinical data sets, in addition to what today is accepted as standard data sets, all of them are available. So this is what EHR.Network has done in the past few years since our inception, 2016.
That's quite interesting. So I'm listening to both of you now. In the last 15 minutes, Rupa talked of data structure and its management, and the fact that there is still a lot of the data in the hospitals is in silos. And Angshuman also pointed out that you can even take a handwritten note and scan it and call it a electronic media record. What's the use of that? And also, I'll come back to you on the open source part. So I'm just wondering, is it possible for India to have a unified documentation system? Can we actually do it? And can this be a building block in health tech to transform the healthcare system, because it's, though it is being done for teleconsultation, that is not the goal of EHR EMR. It has to be accessible even if you go in person, whether you're doing teleconsultation or even if you're checking at home. So it has to be. So I'm just wondering, can a country like India do it?
So I think as I'm sure all of us know, ABDM is a step towards it that the government has taken. Now, can we do it if that's the question? So the way ABDM itself is structured is, I think you can even share PDF documents and share data like that. But actually, I think what your question, Sunil, is, can we get to the point where what we are exchanging is structured data that can
Yeah,
be interpreted, can be computed.
right.
So, if your question is, can we get there? I think we can definitely get there. One of our vision is, in terms of EHR.Network, is to actually provide this service so that all new innovations can start using it. It works in India data with Indian cost structures, and the data is structured, and you're not, just claiming that you are exchanging data electronically. So definitely this can be done. And I think in terms of infrastructure, that they're using Fire to actually exchange the data, and this will kind of help the clinical data sets to start getting standardized. So I think we are a little bit away. They've gone live in the union territories. I think they've kind of going live very shortly in the other states. So I think we'll get there, but I think the pressure has to come from both quarters. One is the citizens have to start becoming aware that this is a possibility, this infrastructure is there, so that when they actually go to their providers, they start asking for it. They, just like how UPI happened, this will also happen once the end user starts realizing that it's there, that the data is theirs. They are the owners. They have to give consent. It is for them to decide. So once this kind of information percolates and is understood by every citizen, then I think it will start happening.
Yeah, I mean, see, structured data comes in various forms, right? For example, let's take an example. Like, say, every TB patient, right, needs to be reported to the system. ICMR mandates that, every cancer patient, for example, record is updated onto their registry. Minimal information that is right now being passed on is still useful. Now, if you are aiming for the holy grail of patients' individual routine data, continuous ingestion, assimilation, cleansing, and actual coming onto the clinical decision supports and overall population reflecting onto population health, we are far from it. And honestly, I don't mind that, right? It obviously looks into you have to look into the larger sector development, right? And I mean, think about it. For the last 15 years, our concentration has been largely on mother-child care, because we needed to make sure that our population, for example, is healthy. That was our focus. Now, as you have seen, our disease burden has totally shifted to non-communicable diseases. And now, for example, you'd have seen a lot of movement towards, say, non-communicable diseases. Now, is patients' routine data is the only element? As I mentioned, that is not necessarily the case, right? I mean, think about in Gangetic Plains, a healthcare expert detects arsenic, contamination in soils as well as potable water, is also essentially a public health step, right? And that can come from various sort of data and doesn't need to necessarily come from routine data. Now, if you look into the ABDM, and I was thankfully part of some of the initial thought process as well. We didn't mandate that, hey, every bit of the data needs to be structured, right? I mean, I'm just telling you, even if an oncologist sitting in Tata Memorial Hospital gets to read, for example, or timely gets an update of a medical intervention meted out to one of the patients, and that is probably good enough for clinical care to start with, right? And I'm expecting that with more and more, and there are tons of other cases. For example, now we are using AI ML, and given a simple lab report printed, it can totally interpret in terms of, okay, this is the test that was done, this was the result seems high, abnormal, etc. These are all possible. So lots of these things will come. ABDM specifically has mentioned that let's focus on syntactic interoperability, right? Semantic interoperability, bringing in this, right, is a much harder thing, right? I mean, just to take a simple example, is leukocyte and WBC a same, right? So you need common vocabulary, you need common standards to be adopted across the country, and that I hope will come in phases. ABDM still allows for this, but is ABDM mandating, no, you have to send me an ICD-10 coding, you have to send me the line codes? No, it is not doing this, because it is not possible. We do not have the point of care systems or even the EHR and other systems capable of producing this information and for a standard to be nationally adopted. So I'm hopeful that with the times to come, right, all this would be possible. It requires systematic planning as well as adoption, right, all sector and awareness. So madam has mentioned, I mean, however we are of our own health, we only go to the hospital when we fall sick, right, or we have some pre-existing problems that we are looking for.
Actually, maybe I'd like to expand on this. I'm still probably like the common person is still not sure about this because, like Aadhaar, I mean, it's clear, okay, these are my details. They are more or less static, whatever biometric, they are updated. I get an Aadhaar card and all that. Then, okay, UPI is also a very clear system. But this Ayushman Bharat digital mission, though we have started, I'm just wondering if the government of India goes around making like a national health information exchange. I mean, how is it going to work? I mean, the data is in silos. I mean, I'm just like, the common person has no clue what will mobile apps be used, how is the data going to be collected, how is it going to be integrated. So that is one aspect. I mean, how are you going to do it, and is it possible? And second, even if we do it, what about the security and privacy issues? Because I guess you understand all the others are very clear, but the and this even maybe actually from it would be a good idea if you can tell something about the Ayushman Bharat digital mission and how you are associated with it, because not many people know about that also. So slightly
Sure.
long
Yeah.
question.
So yeah. So this is a long thing to explain in a short time, but I'll give
Sure.
my best. Right.
Yeah.
So Ayushman Bharat Digital Mission, or ABDM in short, right, is India's endeavor towards changing our digital health ecosystem. Now remember, digital health is not just about individual patient records, right? It's much broader than that. To give an example, India didn't have, right, a practitioner registry. India didn't have, for example, a national facility registry. Our Rohini database was probably the most comprehensive thing that somebody could think about, right? Now these are foundational building blocks, right, which over which all other things needs to be built up. So practitioner registries, the core registries, health facility registry. Think about IRDA has got similar insurance payer registries, different sorts of apps. For example, everybody right now is using some sort of a, at least in the metros, some sort of a health app, right? Is there a registry for it? I doubt, right? You only know, you expect the patient to go about, I have heard about this particular platform, I'll onboard there, I think this gives me benefit. But to systematically change and totally overhaul the digital health ecosystem, these are the foundational registries or the building blocks that you require. Other building blocks are say, think about standards and protocols, right? Privacy itself, right, is another building block. Now, on top of it, right, there are other domain blocks. What do I mean by domain blocks? Health information exchange, is a particular domain block, right? Health claims, for example, is another domain block, right? I do not know, but you must be aware of that, there is a proposed construct called unified health interface, right? Think about it something like in the lines of a digital commerce, where every provider, be it as an institutional provider or like an individual capacity, for example, can say, this is the services or the products, for example, that I bring, right? And they have a platform in an open ecosystem saying, I want to make myself available, and a patient in their local context or even in a broader context can discover them and say, okay, I want to avail this service, I want to get this medication, I want to book an appointment, for example, etc., and that gets fulfilled through this. Now this is another layer which is about UHI. So NDHM that way has got many foundational blocks, and there are about total 7 layers. I'm not getting into totally into this, but one more things that I want to briefly touch about, which is talked about, is the privacy part. All right. Now, so far, right, India has lacked, right, a comprehensive, say, law which covers, for example, our digital health interventions and exchange of information, processing of the informations altogether. But personal data protection bill, which was tabled 2019, was recently reviewed, again, it's been going through various JPC reviews in December 2021. For example, it is very close, for example, to actually being coming out as a law, right? So, I mean, it's far from law, but I'm saying it's close to being passed. That is probably the closest that we have come about, and I expect in the next 2 years, for example, that is going to change, because it's good to have regulations, guidelines, right? But honestly, nothing is going to change unless you can bring accountability, right? And accountability can only be forced, for example, by a by law, right? Written down law that is somebody can say, okay, you didn't do this, this is against the law. So I think that is going to happen. But what I like is this, that everything on our data protection bill is centered around that data principle in this health context, that is me, the patient, right? And there my consent matters. I give, this is not an implicit consent that I just fill up, for example, while going to an hospital, or I concur, or as such. This is an explicit consent that I give whom to share the data, for what duration to share the data, and I can revoke it, because it's not just about giving the consent, right? If I am able to give the consent, I should be in a position to, as a data principal, I don't like it, or for some reasons I want to say revoke that. So those are the things that are coming as part of the data protection law.
So
Just
that's
to
quite
add,
comprehensive. So yeah, I'm
yeah, so
interested,
just to
Rupa.
add a few more thoughts that come to my mind when we think about ABDM. See, the first thing is it's a federated architecture. So what it acknowledges is that all of us avail healthcare from multiple service providers. Our data will get created by each of them, and we're not saying that our data, all our data will now get centralized, or there's a central view. That is not, it's a federated view. So that actually makes me feel very optimistic, because that is reality, that our data will be residing in, in different locations. And as he pointed out, each service provider, when they create data for us, they are only a custodian of data for the patient. The patient is the owner, and each provider is actually the custodian. So now, with patient consent, there are two modes. So wherever the patient is visiting, data is getting created there. And now when the patient visits another provider, and if the data that was created in the earlier provider is relevant to the second provider, then this whole ABDM network with the patient consent will enable that data to be made available, as he pointed out, within the framework of a consent request, which talks about what is to be shared, what is the time period, what is the purpose for which is to be shared. So all that is taken care of. So now what we are talking about is, like, there are two concepts. Every service provider, depending upon the use case, will become a health information provider or will become a health information user. So when this concept is there, the data will move, but can be given to the second provider if the patient says, okay, I give you consent to keep it forever. Okay, then the data will move here and can continue to stay here. Or the patient may give a consent that says that this is just for this encounter that I'm having with the second provider, that this data is going to be available. So that's first point. And the second point is, they have this concept about care context. That means all data can get grouped into care context. That means if I have visited provider 1 and on, just say, March 10th, and a set of data has been created, now that can be considered as one care context. So maybe there are 4-5 health clinical data sets that have got created. Maybe my vitals were taken. Maybe I visited the cardiologist, and the cardiologist, the diagnosis was made. So etc., etc., etc. Some tests were made. So all that now becomes a care context. Now, what ABDM has also done is, they have identified, if I'm not mistaken, please correct me, I think 5 health information types in terms of exchange as FHIR bundles. So that they have, these 5 has been well thought of. They kind of cover most of the use case scenarios. So it could be like an OP, or it could be a discharge summary. I think now they've added the vaccination aspect. Then the diagnostics are there. So it kind of addresses what are probably 95% of all the use cases. So in this mode of exchanging data, one, it's federated, so the data is not got centralized. Okay, with patient consent, they can be an innovative solution, which they now call as the PHR solutions, where all the data can come together, and somebody else can be offering that service. That is, collect data from all my different providers, bring it together, and now this becomes the holy grail for this patient to now start sharing it with another provider that they go to. So it allows a lot of innovation. All these possibilities are there. And what I feel is, as always, it will start with early adopters. Maybe the metros will lead the way. The solutions will come out. People in metros will start using it. It's similar to, my understanding is, it's not going to be forced down anybody's throat. It has to make business sense. Only then it will start getting adopted. That means the patient, who's the customer in this industry, starts asking for it, and there is a business driver, and I think it's going to happen. It's like, why does every merchant today offer a UPI payment? It's not mandated. I mean, they can still do their business without it. So innovation has to happen in such a manner that it is just sheer business sense, and this will start getting provided. So that will come with that awareness. And I think one of the things that the team keeps talking about is, India each patient will realize that they are data rich. So there's so much data that you now own. Is that what is going to drive all of this? So there are a lot of discussions happening. So only time will tell us as to which one will take off. But I'm very optimistic that it will take off.
If I may add also,
Sure,
and this is probably, requires some reinforcement about the federated health record architecture, right? I mean, see, in a typical health information exchange, I'm not saying centralized, shared health record is bad, right? It depends on country to country as such. In India, where healthcare is so service delivery is so decentralized, it probably makes sense to have and remember, our data production bill plays an important word, data fiduciary. So every hospital, systems, that becomes like a data fiduciary, which is processing the data, and which is it for the data principal that is like, say, me or a patient. Now, the federated health record system means that it is like, available on demand. So there is no central repository nowhere like, the data is being stored, right? The other aspect is this: even the ABDM, for example, the gateway through which all the communications and things that happen, right? They do not have access to the data. Even if the data is passed through this, they have no way, for example, to decrypt the data, because the encryption and the decryption applies to the requester as well as the producer, right? So there is nobody else, for example, who can even unpack the data other than the original requester. This is have been taken. This was one of the most important things that we had to think about how to enable this. So that's a very important part. But security is a much broader, right? It is not just about encrypting data in transit. It is not just about encrypting data in the rest. It's also about the data governance part, right? And that's where the legality comes into the part, right? Remember, when you get a consent, you are giving a consent for a purpose, right? So if somebody says, I am going to use this, look, I need your data, for example, for your care management, that means they can't use this information for processing or leveraging for some other purpose. Say, for example, oh, this person is can you mine this person's information, for example, for better promotions? No, that is not allowed, right? How many times have you gone to the doctor, for example, and by the time you come back, you get a promotional message, right? And you wonder, how did it happen? Now think about it. When this becomes a law and you have given consent of data sharing for care management, you can go back and say, who gave you the authority to send me promotional information? Now that's the groundbreaking thing, right? And you can revoke, for example, the consent. I'm withdrawing my consent for you. They are mandated to delete the data. Remember, this is stronger than even GDPR, right? In our data protection bill, it says that you have to delete the data. The data is not for you to keep forever. It is only for the purpose and for the duration that the data principal has authorized you to do this. So these are some of the salient things, to be, and there are a lot more other aspects in terms of security, right? Consent on a narrow, say, topic may be fine, but think about security, and especially in this age of AI ML, is not just one dimensional, right? You gave consent for this, you gave consent for that. The triangulation of the data that can happen, for example, maybe you can still de-identify you, right? Maybe it still goes beyond the original purpose of what the information is sought about. So, but I think it's a great start, right? I think that's what I'm really optimistic about.
Yeah, and just one more point that I want to add. As part of ABDM, one more paper consultation paper that's come out is the data retention policy. Correct. So now what is happening? A patient goes to a service provider, data is getting created. And then we are saying that this is a federated architecture. So as and when data is required, you ask for it from your provider and your provider has to provide it. So now the question is, what is the duration for which that provider is expected to keep your data? Correct? Because I may have visited somebody, and does it make business sense for a provider to be investing to manage the data? Because now they are on the ABDM network, and as and when they are connected, and the patient gives a consent, and somebody is requested. So I think some thought has gone in there. I think it's between 4 to 7 years. Is that the number, if I remember right? I think that's the proposal. So now what happens is, see, now it's also the onus is on the patient to be well educated, to be well informed, to say that don't expect that the data generated for you is going to be managed by your service provider for your lifetime. It's not going to happen. Now you are the owner. Now you have to get proactive. I'm saying all this is going to start from the early adopters. They will be a set of us who are, who are probably our ears are opened, as our minds are open to new thoughts. We will take it, and then it will percolate. So it works both ways. It's not just about, the service provider, has to now be a custodian and provide. The patient also has to become more responsible. You have to. So now they're going to be a new breed of providers who will now start enabling the individuals to start maintaining their lifetime record. So that's going to be a whole new industry, whole new variants. And now that can become the master, but it can be a commercial aspect. So it gives room for a lot of innovations.
So, actually, it's very daunting to hear. There are so many layers and so many complexities. It's very daunting to hear, but also it's heartening to know of the progress that has already made by the government and, people like yourselves. But I was wondering, like we already have an Aadhaar card, we already have access to UPI. How far are we? And even if that is possible, say I have an ABDM smart card that is connected with a central repository with all safeguards, and I can go to the private hospital with it, I can go to the government hospital with it. If I go on vacation, I can use it. For the medical insurance office, I can use it. Is such a thing possible, and if so, how far are we away from it?
So yes, I mean, it is possible. Obviously, a lot depends on the point of care, right? Today we have the standards and protocols to allow that. It didn't happen say 2 years before, right? But today we have that. Now a lot of ground that needs to be covered, for example, on the point of care side, right? And I'm not just talking about hospitals, right? I'm also talking about say the primary health centers. I'm talking about say the different health techs for it that have come up. For example, there is an evidence-based care services for endocrinology by different health techs as such. They are AI email developed for lifestyle disease management, etc. Now to some extent, those who are born digital, this sort of a health techs, right? It is easier, right? And that is a good thing. For the others, it's going to be a journey, right? And that journey needs to be enabled through various incentives, not just to be meted out by government, but the incentives that the providers say, okay, if I come onto this, I have a good rating, for example, right now I'm able to reach out to far more patients, and the patients know that if they come to me, they get an electronic health record generated that is portable, that is accessible, that is referable anywhere, right? The irrefutability on non-repudiation of that information that's generated is as much valuable, right, as anything else. So I think it will happen gradually. I do see that providers who leverage clinical information for both for quality of care and continuum of care, they would be the first to onboard that, right? Apart from the different health techs that said who are already born digital, to do this. At the same time, think about PMJ. We are the largest universal health coverage provider in the whole world, right? We have more than, I think, close to about more than 30 or 36,000 institutes that are part of them, right? And that is leveraged by say majority of the Indians below a certain income level. And that is easy to do that, right? Because at least we are not saying, I mean, let me rephrase that. It's not easy, but government can say, for example, the least you can do is generate one electronic discharge summary, right? Even that is good enough. So I think it will happen gradually. This is a long journey. Whether we leverage the routine individual information, I think that is more about, like, say, I don't know, 5 years, 10 years journey, which will, like, will come progressively. But all other aspects, I do think like this is possible either from the payment side or from, like, as I said, like, lifestyle diseases, personalized healthcare, right? This is still possible. One big aspect that, and I am putting it on government, for example, because they have a big role to play, is awareness, promotion, right? That typical, like, information, education, and communication. This is the new concepts that we are coming up with. How do you expect somebody, like, in the remote villages, somebody who's 80 years, like, to understand about consent, right? What is the implication of giving the consent? Now, just like, for example, now you think twice in terms of sharing your OTP, right? Because, like, throughout every place, every bank, every government, every information pamphlet that you see, you said don't share your OTP, right? This is part of the education. This is part of the awareness building. Now, that is the part I think the government, and even otherwise, for example, the organizations have, like, healthcare providers have a big role to play, because unless we can build up this, like, awareness amongst the patient groups, is going to be a difficult task.
Yeah, Rupa, you can add to that.
Yeah. So, see, in India, typically, and I think the National Health Policy of 2017 also talks about it, that our healthcare system is pluralistic in nature, because inherently as Indians, the government allopathy is there, but Ayush healthcare practices, all of us in our lifetime, most of us, let me not say definitely, but most of us have used those systems. Okay. So one of the things that the government realizes, the first point is we are a signatory to the Sustainable Development Goal 3. So by 2030, health and well-being is a goal that we have to meet. So all the things that we are talking about in today's is the government is moving in that direction because we are a signatory. We have to ensure that. And second, in a population of that we have, it is not sustainable for us to go on the curative mode, correct? So wellness is very important, and then the Ayush practices are kind of focused on the wellness portion, correct? And the national health policy clearly indicates that what is lacking in rolling out large scale public programs with Ayush practices is there's lack of evidence. There is no data recorded, correct? Now, if you look at it even from that point of view, an EHR of an Indian today, okay, a holistic EHR of an Indian today will contain data or should be capable of containing data of all these practices, correct? And then you have evidence, and then you have a holistic view. So today, what happens if you look at Ayush practitioners? They do view, the diagnostic reports, the lab reports, or, the radiology reports. They view all of them and they take inputs. But for the other way around to happen, that what have they assessed, how the treatments worked over there. So there has to be this means by which what they have entered should be understood or interpreted or accepted, whatever words we want to use. Only then, for a country like India, it will, because many Indians actually use those healthcare systems. They have deep beliefs in that. And a realistic EHR will contain data, should contain data of all of that. And now, and a holistic a wellness regime means that in India, all those systems are very, very relevant. So taking all of this into account, what is required is, even when we are talking about a data exchange, all the players, all the practitioners, all the facilities in each of those spaces also have to start coming on. And as it was clearly mentioned, Education is like extremely important. Like, what does consent mean? And when we talk about privacy, but I've met a lot of people, and I'm sure you will agree, privacy is a very personal thing. What each of us consider as privacy, that rule does not apply to everybody else. For somebody who is seeking treatment, okay, privacy of the healthcare data is not a priority for them. Is not a priority. That doesn't mean that that they have to compromise on that. So privacy itself, hence consent. Consent is actually indicating what is the individual's assessment of their privacy. What are they ready to share? How long are they ready to share? For what purpose are they ready to share? So this consent document has to be understood before you actually give it, and then it would capture what is the privacy statement of every individual, and then you're honoring that privacy statement. So once we do that in a country like India, where the priorities of what is privacy vary so much, then the uptake, I'm saying the challenges that you will see in the urban areas or in the Uber sectors, or whatever we want to talk about, those will be very different. So then when you start applying with clear understanding what you're giving consent, what it is going to be used for, then many of these challenges may actually not be relevant on the ground.
So anyway, I'd like to thank both of you for simplifying all these issues. So before we go, I'd like to hear your final thoughts. Like, what would be your roadmap? What do you think like India should do for the next 10 years to sort out all the complex issues you have mentioned, and how we can move forward? So, what do you expect India to do, the government to do, the industry to do? I mean, in whatever way you want. So I'd like to hear your brief roadmap for the future.
So my
Sure.
thoughts here are, we have to take an ecosystem approach, right? Everybody can't do everything. So there has to be players have to be encouraged to do specific things in the ecosystem, so that it enables, it makes economic sense for the player, sustainable sense for the player, and they enable each other to move forward and to make this happen. For example, if you take what our vision and hence our mission is, we want to be part of the ecosystem. We want to provide services. So using them, you build health tech solutions. You build on top of this. This is our service. You pay for what you use, then you build on it. And what you build is going to be ready for a ABDM network. It's going to be generated structured data, and it allows for a lot of innovation, and it works across a wide range of use cases. So this is the only way that we as a country, given that our resources are very limited, we cannot be rolling out those extremely expensive solutions that are there out in the West. They don't work for us. It just doesn't make sense for us. So this is how we have to take the best practices, technology from them. We are very, very good at that. We have to understand all the pains that they went through, learn from them, take the right practices, bring it here, and roll out solutions that make sense to the Indian market in an ecosystem manner. Each one bringing what we can bring into the ecosystem, and others building on it. Because each one building from scratch to the top, they're going to be compromising at such level, because they are not going to make it a business success, because if they have to have resources to build from bottom to top, because it's an extremely complex market.
And I would plus one onto that, right? And if you look into the ABDM perspective, I mean, this is precisely the thought process, right? Government is going to make sure that the standards and protocols and the policies are in place. And for the first time, at least from my limited experience of working in this space, I'm so glad that everything is happening in a consultative, open manner, right? That itself is a big departure, right? Enabling the ecosystem, right? Government not doing something like say, oh, let's build this up, right? Let's build up a digital locker and put this up. That is not the thought process at all. Government thought process is this: we are going to act on the policy. We're going to make sure that the policies are also in line, supportive of the standards and the protocols that are being devised, and then let the ecosystem play on it. The other aspect is this: if you really want to say jumpstart this, right? And before I go there, one aspect is this: I think we need to be extremely cautious that there is no monopolies that are created, because there are plenty of examples. Look into the United NHS, right? On the EHR side, there are essentially two right? Like, two providers. They have the duopoly. We do not want that, right? We want, like, fit for purpose, context appropriate solutions that are available, right? Maybe it is not the most fancy things, but something that works. All right. Why do I need to use Zoom, for example, if I have Jitsi? I'm just giving an example, right? For video consultation, right? Why do I need to? That's the way that I look into this. Yes, Zoom gives you a lot of things, probably that is appropriate, but a simple Jitsi meet, like, is free, open source, is good enough. And for many, this is probably will suffice, right? And for this, one of the things that I believe, like, government and in future also, that we should focus on the digital public goods. For example, one of the products that I contribute to, and, like, Thoughtworks especially does, is, like, ABDM, right, which have been working for the last 10 years. This is now, like, as part of the NORAD, UNICEF, like, digital public goods registry. I think more and more such things needs to come on, right? Like, where it will be still be open people for to adapt. If there are any gaps, for example, people can, like, private players or others can come in, can fill in this, can provide, like, better services, like, based on this. Another thing that we need to continuously keep working on this. See, nobody has seen the future, right? This is a new journey. And one aspect is this: ours is a very different from other systems, right? Estonia has gone with blockchain based approach because it, like, works for them, right? United States, like, even if they want to rechange, for example, that the cost of change is going to be prohibitive enough for them. Now we are starting from a green field. We have the advantage of learning from the mistakes, right? And we have the advantage of starting something that is, like, based on evidence, right? Like, of work. So if we decide to go based on evidence, right, we can't go for about, like, so 10 years will be there. Let's come with the empirical data on the usage. So continuous evolution that must happen, right? So I'm still hoping that the evolution is progressive. It is based on empirical data, right? And that's what you need to hope for, right? I'm not going to predict for what is going to happen, like, say 10 years down the line. Maybe, like, everybody just, like, Star Trek, okay, Captain Spock speaking, can you do this, right? But yeah, I mean, maybe it will happen, but let's take it step by step, one step at a time. Focus on, like, on a larger population, from my perspective, right? Also, clear trends in terms of personalized healthcare that can still happen. But in terms of a unified, like, healthcare, digital health for India, we need to think broader. We need to think about absolute common minimum, things like the data minimization, right? Ma'am talked about that 5 health, like, artifacts, document artifacts. Why? Like, there's a question about why is the 5 was decided, because this is the 5 types of documents. If patient goes, right, to a doctor or a provider, these are the 5 types of documents he or she gets, and that is good enough to start. So let's not try to think through the entire thing, because nobody has done that. Let's take one step, baby step at a time. Make sure we put it in practice, learn from it, and do that, right? I would have been, like, super happy that in a financial domain we have this practice of sort of like a environment through a certain, like, policies and other things are relaxed, so that, like, for certain experimentation. We still don't have that, but maybe that is one way of going there as well.
So I'd like to thank both of you for that very comprehensive look at EHR, EMR, and ABDM. So at least I found it quite enlightening, and I'm sure it's very useful for our listeners. Thank you so much. Thank you both
Thanks.
of you.
Thanks,
Thank
Sunil.
you. Thanks.
Thanks.
Bye.
Thanks for having us.
Bye.
Bye-bye.
Bye-bye.